I'm really excited about this episode because we talk all about exosomes, which are the newest, sexiest frontier in regenerative medicine. And they could be the key in lowering inflammation and curing a lot of diseases. So stay tuned, exosomes coming up. Hello everybody, I'm here today with a very important research scientist who also happens to be the founder of an exosome company called Kimera Labs. Dr. Ross, welcome to the Anti-Aging Hacks Show.
Thanks, Faraz.
So I want to start by asking you, for the audience, your background and how you got into medicine.
Okay, well, I had considered being a physician my whole life. When I was 20, I was accepted to the University of Miami Medical School, but I went off to Europe. Then a few years later, my father came down with myelodysplastic syndrome, which progressed to leukemia, and that happened over a period of 6 years. So he was a research scientist. He was an oceanographer, he used to fly into hurricanes. So we started reading like a research scientist does. It's a lot harder than you would think to try to become a leukemia expert overnight. And we weren't successful in that, but that did start my entering grad school in the biochemistry department and then transferring to the immunology department. So in effect, over an 8-year period, I got 2 educations from 2 different Ph.D. programs.
Okay, Dr. Ross, that seems cool. What got you into exosomes?
Culturing cells, and culturing cells from different ages of patients. I thought that cellular therapy was going to be the way forward. I thought autologous, individualized cell therapy was the way forward. Certainly people have seen benefits of using bone marrow, PRP even, stromal vascular fraction from adipose, and all of these things work. But I figured that if I could express more autologous cells, I would have better outcomes. And that turned out to be true in many respects, but also in other respects it wasn't. And that was kind of perplexing. Every physician who's treated someone with their own cells or products has seen a variability in the outcomes. It's what's given stem cell transplantation such a bad name. And you know, I feel bad for physicians because they use the same protocol for each patient, but then they find that they have these varying results and they don't know why. The reason is the patient's fault. If you could just explain that to the patient to begin with, that their cells are not so functional. And everybody, no matter what your age is, they have different quality cells. So in expanding cells in the laboratory, I noticed that younger cells were easier to expand than older cells. In some cases, I couldn't even expand the older cells for a period of, say, 6 months. And in one very important case, I couldn't get the cells to grow at all. Now, it turned out that that particular patient was very important. It was the wife of the plastic surgeon that I was working with, who I had built a lab in his kitchen, basically, in his clinic. So it was very important that that succeed. So I took the conditioned medium supernatant from an 18-year-old paraplegic that were growing very well and put it on top of the 70-year-old. So every other condition is the same. The only difference is whatever the younger cells were making, no cells, just whatever they were making. That caused the older cells to start growing, and that was sort of the aha moment as to what could be achieved.
That's amazing, and we're going to dive a lot more into this, but exosomes seem to be blowing up right now. They're the darling child of the regenerative world, if you will, but not a lot of people understand what they actually do or where they come from. So for the audience, could you explain what exosomes really are?
Exosomes are the method with which cells communicate with each other. You might have thought previously that a cell gets up and moves. It doesn't really have to do that or do that. So if you think of when we are embryos, we have an endoderm, a mesoderm, and an ectoderm, right? The mesoderm is that's why they're called mesenchymal stem cells, is because they're controlling the growth of the ectoderm and the endoderm and the other cells around them. A liver cell doesn't care what a kidney cell is doing during autophagy. The mesenchymal stem cell is only there to be a signaling cell. That's why Arnold Kaplan changed the name to a medicinal signaling cell as an MSC instead of mesenchymal stem cell. Because although you can convert them into different lines in the laboratory, that doesn't happen in the human. Because you take the cell, you implant it, and it dies. But before it dies, it does have the chance to secrete these exosomes, which go into the endogenous stem cells and cause them to regenerate. So the exosome can be thought of almost like a football. And the quarterback is the mesenchymal stem cell. The liver cell is the receiver, and he kind of throws a Hail Mary pass to him. and he catches it, and he gets the information to do what he needs to do.
Gotcha. So the quarterback isn't so important, but the football in the air, and when it's caught, is what's good doing the job.
Right. And you can also think that why people like to argue against exosomes is to say that the mesenchymal stem cell, as the quarterback, it can look around and decide what it needs to do, if there's inflammation or if there needs to be regeneration. But that's if the cells could persist. When you put them in there and they can't persist, they don't have time to do that. You know, they're too busy trying to find nourishment, and so they're going down more quickly than they can assay the environment around them and change their growth factor profile.
That's amazing. So I have a follow-on question to that. So let's say we inject these, or the quarterbacks, which is the mesenchymal stem cells, are throwing these footballs in the air, which then are having really good downstream effects. And the footballs happen to be exosomes. And you're saying that we don't need the mesenchymal stem cells to stick around, but once the footballs are in the air, they cause this cascade downstream that just builds on itself, and it continues to improve the conditions in the body for quite a while.
Right. And it's almost like when the receiver receives it and he's going to throw it off to one of his partners running next to him, that one receiver can throw off thousands of footballs to all of his teammates around him because he can replicate it.
That's fascinating. So you kick off this domino,
right,
that then kicks off other sets of dominoes.
A cascade.
A cascade, which is really beneficial. So which leads me to my next question. What are the benefits of exosomes for people out there?
Well, you can think of it as, so exosomes, I've always said, are like the word fruit. There's apples and there's oranges. I'm starting to think about it as an electric car. You know, you have a Chevrolet Volt or a Tesla. You have an old Chevrolet Volt versus a new Tesla. If we want to be young, we have to take young signals. And young signals, the youngest ethical cell that I can get my hands on is from a placenta, which is a very nice place to get it. It comes from a C-section. It's clean, it's tested. I have the placenta for about 24 hours. I expand the cells out of the placenta and I make a master cell bank, and then I make a working cell bank. Every month I go back to the working cell bank, I grab some new cells and I start using those for a month, and then I throw them out. So I'm not using old cells. I'm using a constantly replicable type of cell from a young placenta.
Great. And so when this is injected into a person's body or on the face or whatnot, what are the benefits to that person as a result of this exosome injection?
Well, it's an interesting thing that you say it that way. The methods and manners of delivery are a lot more variable using exosomes. So since exosomes aren't alive, they don't need to be cryopreserved, they need to be frozen, because all you have in there are proteins, messenger RNA, and microRNA. The size of these vesicles is 130 nanometers generally. The definition of an exosome is 50 to 250, but the point is they're generally about 130 nanometers. The size of when you nebulize something, the size of that particle is 5 microns. The size of a cell is about 3 to 5 microns. So you can't nebulize cells, they fall apart, but you could nebulize exosomes. So that small package gives you all kinds of ease. You would never want to inject a cell through a 30 gauge needle. It would shear. Exosomes are far smaller than a 30 gauge needle, so you don't have that issue.
Wow. So you mentioned just now there's components of an exosome, there's proteins in there, there's messenger RNA, there's microRNA. Can you explain what these mean and what they do?
So if you have a cell, the DNA is in the middle and it's in a nucleus. It's encapsulated there. It expresses messenger RNA and proteins out into the cytoplasm. So you could think of the exosome as just budding out that cytoplasm. You have messenger RNA, which are the blueprint for producing many, many more proteins, and then you have the protein. The thing is, proteins have a very, very short half-life. They denature rapidly, they're very labile. Anytime we've tried to, say, use TNF-alpha in anti-tumor clinical trials, it hasn't worked. Because by the time the protein gets to where it needs to go, it's gone. It's not functional anymore. And when I was in the biochemistry department, I used to express recombinant proteins. And in order to get them into an enzyme assay, I had to run from expressing them. Like, I had to be there all weekend long. I'd start on Friday. I wouldn't get my data till Monday afternoon. And I couldn't leave. Because as soon as the protein expressed, I had to get it right into an assay. So in my mind, when I took the supernate and the conditioned medium and put it on the older patient and it worked, I couldn't really understand how this was happening, because it's sitting there in the conditioned medium at 37 degrees. How are these proteins still so functional? Well, that's not what's happening. What's happening is that the messenger RNA, from which you can create thousands of proteins, is protected by this liposome. That liposome keeps proteases and RNases out so it doesn't break down the protein. And then that's how they're functional. So rather than create a protein, put it into your vein and hope it gets to your kidney, you can put the exosome in, the messenger RNA goes to your kidney, and then in your kidney it expresses the protein there in situ. And that's how the body actually works.
Wow, that's amazing. So you're sending out the blueprint of a protein along with the protein itself, but to your point, the protein could degenerate in a few hours.
It's almost like what we're doing now with 3D printing. Why send heavy rocket parts to the moon when you could send the blueprint for it and 3D print it on the moon?
Yeah, very good point.
Yeah.
And so how long does this messenger RNA stay in that cell and keep creating those proteins that we've encoded for?
So a VEGF has a half-life of 4 hours. The VEGF messenger RNA has a half-life of 4 days. So you can make millions of VEGF proteins off of that. The longest period of time that a messenger RNA has been tracked in a rat is 30 days. So some of the messenger RNA are gone in 4 days, some of them are gone in 30 days, and it's a scale in between that.
Okay. And I've heard you say before, Dr. Ross, that reducing inflammation is a key benefit of using exosomes. How does that happen, and why is that so important?
Well, if we're starting to think that inflammation is the cause of everything, atherosclerosis to cancer, stopping inflammation is important. I mean, kids don't have a lot of problems, do they? They generally don't get tumors. They don't get arthritis. So what a baby exosome does is whatever a baby cell does. And the beauty of this and why we've succeeded is because I don't even have to know everything. I mean, I'm learning, but there's more things than I can think of that a baby cell does that is beneficial. And what are those things? Those are being anti-inflammatory, right? If you cut an embryo, it won't scar. That's because of the anti-inflammatory factors. It is growing, which we are not. And it also doesn't get cancer. It's expressing whatever it expresses. And so in the case of cancer, most of the time people get pancreatic cancer because they have a tumor suppressor mutation, either P53 or P10. So you can think of it as you have a tire. The tire is great when it's new. It gets old, it gets a hole in it. It loses its air. You can put Fix-A-Flat in that and pump the tire back up and continue on. So the young exosome in an older cell is like a Fix-A-Flat, which regenerates that cell and makes it act like a younger cell.
Mm-hmm. Okay. Mm-hmm. And so let's talk about inflammation for a minute, right? When you fall down on the street or when you have a viral infection, you get acute inflammation in the body, which is very good because it helps fight off all the infections and get them out of the body and train the immune system. But we're talking about long-term chronic inflammation, which is almost an epidemic in our society. As we get older, we start to get inflamed. So I know that there's tests out there we can use, like the CRP test, which I've done myself, which measures your systemic inflammation, meaning all in your body, which was pretty low, thankfully. But is that what people can go to check their inflammation, or do they also have to pay attention to local inflammation that may be in specific tissues that they're not aware of?
Well, that's interesting. I mean, when we want to treat someone, say it's a face or a tendon, we go through a lot of effort to cause inflammation immediately, to get the cells to traffic there. And then we want to stop the inflammation with the exosomes so that we get the cells to the environment and then we reprogram them to do what they need to do. So it's very important. In chronic inflammation, that's coming from, say in the case of arthritis, it's coming from a CD4 T cell that is antigen specific for some protein in your body. That may have happened when you had a surgery or you had a fall. These things just randomly happen. Inflammation comes, suddenly you start recognizing yourself. Because when you make T cells, they recognize self, they apoptose. But if that happens, you can trick the body into turning those cells off, making them become anergic, by adding the same proteins that a regulatory T cell would express. Things like TGF-beta3, IL-10, PDGF. And that's what happens. We are pretending that we have an upregulation of regulatory T cells by inserting anti-inflammatory proteins.
That's amazing. I'm a big fan recently in the last 6 months of TGF-beta3 because I found that it is the one protein that responds to injury, but it doesn't scar it. So I've been doing microneedling in my hair or my face or on a couple of scars that I've got, and I know that it's not going to cause any downstream effects or permanent scarring. So of course, we'll talk about more of that and even after the podcast as we look at some microneedling and exosomes. Let me ask you another question. On growth in particular, we want the exosomes to spur on growth because in our bodies after 20, as you said, it's a fight between anabolic and catabolic states. And people in the anti-aging circles are saying that you want to be anabolic at some times and you want to be catabolic because then the body goes into cleansing out the different proteins and it repurposes all these cells, does apoptosis and others to make a really lean, mean functioning machine that can survive a winter with no food, for example, right? So how does exosomes help us with the growth, but also balancing the catabolic effects that might be necessary?
That's a very good question. It's something I've been thinking about a lot lately. The catabolic issue is due to these senescent bodies that are being expressed by our older cells that are getting older and dying. There are groups, I know a few of them, that are using plasmapheresis to remove half of your plasma, keep the cells, replace that with saline and HSA. The idea being to take out, well, they don't know why it's working, but the reason I think it's working is because you're getting rid of these senescent large bodies. So you're giving your healthy cells a chance to advance more rapidly. Now consider what could be done at that time when you're making that therapy and how you could modulate that saline that you put back in. There's lots of things you could do. So I think that's what's going on there. What I'm trying to do with the exosomes we're making right now is definitely anabolic and replacing the growth factors that have been closed. The example that I always use is lactase. You're not supposed to be lactose tolerant. The lactase gene stops being expressed normally at 3 years. If you have a mutation, you can drink milk forever. But that happens with every growth factor. That's also what happens with cancer proteins. If you turn off a tumor suppressor just because of methylation, you might even not have a mutation. It just happens that closed, like all of our proteins close. Then the cells start growing uncontrollably. If you can open that gene back up, which is what is done a lot of times in leukemias, you use like decitabine as a demethylation agent. You're randomly trying to demethylate as many genes as you can to hopefully get them to start expressing again. But we're doing that with growth factors. We're doing that with all kinds of things.
Okay. So if we use or inject these growth factors with exosomes and lower the inflammation in the body, what kind of real world results are people seeing that you're working with?
Well, we've treated so many people by now, something like 30,000. We've seen everything. In Ecuador, we've even seen a woman come out of a coma because she had atrial fibrillation. Her kidneys started to shut down. Her creatinine levels were going up. She was in sort of a uremic coma. And my partner down there that I work with, it was his grandmother. So he said, well, we're taking her off of feeding tube tomorrow. So I'm just going to inject this now as a last ditch effort. And she woke up 5 minutes later. She said, I'm thirsty. How could that be possible? Now, this was over a month ago. The next day she got up, started doing yoga. They put her in the chair. They had her home 3 weeks later. She had her 96th birthday, and right now she's fine. Her CRP levels went down. Her creatinine levels went down. The only explanation I can have for that is that she was in a coma because of the inflammation that was occurring in her body. It put her into a coma by stopping that inflammation immediately because we have this biphasic event in the exosomes. You have the proteins, which can act immediately, and you have the messenger RNA, which are going to take a while to express more proteins. So over and over again, that's what we see, is that the protein component stops inflammation within 15 minutes. I mean, you can see it. When we microneedle your face today, we're also going to make the inflammation go away after we clog it. And that's what's really made the providers like it so much, is that when you can see inflammation stop that quickly.
Fascinating. You've also shared examples in previous talks that I've heard you give where a friend of yours possibly got his face burned.
Right.
And you injected him 3 times over a week, every day over a week, and the results were unbelievable.
We actually only applied that topically because he'd already burned off the top layer of skin. So he threw water on a gasoline fire, and this was in October of 2014. I had sort of discovered this in March of 2014, so I started freezing the product, not knowing what I was going to do with it. When he was burned, I was able to go ahead and give him 250 milliliters and say, apply this to your face topically 3 times a day for 7 days. And by 7 days, it was gone. I mean, he was beautiful. Not only that, he almost got a free facial peel because all of his pores were gone, and he had sort of a baby face. Because again, what do babies do? They express 30 different types of collagens, 8 different types of elastins. By his age, he was probably only expressing 8 types of collagens. So by putting the messages for young skin in, he ended up having baby skin. And he just came into the lab 2 days ago. he looks great.
Awesome. So who should use exosome therapy? Who's a good candidate for it?
I feel that wherever you are and you want to stay there, you should use it. You should use it once a year. Definitely, and you can't wait too long. I think 40 is a good time. Why isn't 35 a good time? 60 is not a good time. 70 and 80 are really not a good time. I mean, I've had 70-year-old patients that I have thrown the kitchen sink at, not worrying about money, and you just can't, there's nothing there to work with. You can't get these cells to start performing if they're not there anymore, So it's definitely, let's say at least a 50-year-old should be doing that. The same as using testosterone. Why do you have to use testosterone? Because you're not expressing it, right? So when that starts to happen, you can think about everything else that's not being expressed.
Right. The whole cascade, the symphony is in its downward spiral.
Right.
You've got to stop that. And so you're saying once a year is a good time?
If you don't have any issues, yeah.
Okay. Why should somebody not use stem cells or PRP instead of exosomes? What's the difference?
Well, I actually don't say that. I say that they are tools in a kit. When you could use fat, and again, I did this in Ecuador. That's where my family's from. I have a lot of ease there, right? If you come in with a knee that is, you have a cartilage defect and pain, really a gold star way of doing it would be to put fat in on day 0 or bone marrow. Bone marrow is even better probably, but some people hurt. Taking that. And then use the exosomes pre and post. Use them as part of a protocol, a treatment regimen. Because the cells definitely are in the fat. The cushioning of the fat, without fail, the patient won't have any pain 2 or 3 days later. Now, a month later, if you just put their old fat in, they're going to have the pain again. But if you use those cells and work with them, you can have a great output. That's why I don't understand why we have to have these different factions of bone marrow saying that exosomes aren't, what we need. When we need both, if you really could add bone marrow up with exosomes together, you've got a much better outcome. So you just need to know when to use them.
Okay. Would that be akin to using a bunch of quarterbacks and a bunch of footballs at the same time?
It would be, yeah. I don't know how to explain that. That the cells are not comfortable when you put them in. They were ripped out of their environment. In the case of when people used umbilical cord, which I never even sold, they're in DMSO, they're not happy, And when you thaw them in your hand with the DMSO in it, the DMSO kills them as soon as they get to room temperature. So that's a major issue with what people are saying. They're putting in dead cells. Well, the cells weren't dead when they froze them. And I could have gotten cells out of that in the laboratory. But in the clinic, you can't do that, So,
Dr. Ross, since exosomes are so small, how do you know you have an exosome? How do you know you've got an exosome?
It's a very tough question. The only thing that consoles me is that everybody in the world is having a difficult time identifying it. And I'll explain why. I said to somebody the other day, do you know why you don't know much about exosomes? Because neither do we. Now, I really believe I know more about exosomes than anybody in the world. I mean, I have a staff of 40 people, 6 PhDs. We have a lot of data. But when you go to academic conferences where people are discussing exosomes, so this is a quote from Jenny Jones from the NIH. She said, we put together an exosome preparation. We sent it to 19 different labs, and we got 19 different results back.
Wow.
Yeah. It really is a new science. And rather than be frustrated by that, as I tell my staff, I said, listen, we knew atoms were around 2,000 years ago. We couldn't see it until we had atomic force microscopy. But the first time I saw a phenol ring was like a big day for me. We also, Einstein proposed that gravity could bend light, but he didn't see it until it was experimentally tested. And that's what's going on with exosomes. We know they're there. We can see them by electron microscopy. Now new hardware and methods of characterizing them are coming out. So there was a machine I was using for the last 2 years called a nanocyte, and it bounces a laser off of your solution. It can see particles of 100 nanometers. But the problem is you don't know if that particle is an exosome or a piece of extracellular matrix or sugar or whatever it is. So really the best way up until recently to really characterize and make a repeatable product was really just the protein concentration. So all these new methods, protein concentration is the one that all the labs in the world really is the go-to, okay? I was contacted by a company that makes a new type of fluorescent microscope that won the Nobel Prize in 2014. Because when you try to look at a fluorescent antibody, you do so with a laser. If you turn the power of the laser up, you quench the fluorophore. So you don't have time to gather enough photons before it's gone. So the Nobel Prize was for a redox reaction that makes the fluorophore blink. So you can use a lower level of laser light. It saves up the energy, blinks out the photon, saves up the energy, blinks out the photon. And so you can look at the image for a longer period of time, get enough photons that you can get a much smaller resolution. So for the first time in the world, I have a photo of the Kimera exosome. Now those antibodies that I put on there can be anything. They can be to surface markers, they could be to VEGF inside of the exosome. So it opens up a whole new world of being able to characterize the exosomes. And one of the biggest problems about exosomes is they come from all parts of the cell. So they're all different. Everybody knows that even from one preparation, it's a heterogeneous mixture of exosomes. Some of those have CD9 on them, some of them have CD63, some of them have both. So we needed to be able to have hardware like that, to be able to go to the FDA and say we have a repeatable product. So now bringing together all these different assays. So I've already got the physical characterization assays done. Now I'm doing functional characterization right before we go to the FDA.
That's great. So speaking of the FDA, there is now, they've actually requested that the companies that are making exosomes go through their regulation by the end of this year.
Right.
What does that mean for Kimera Labs?
November 2020. It's like the roaring 20s, what they call it. I'm actually very excited about that. The recent outbreak of 5 serious adverse events was actually positive for my company because people don't want to take risks anymore. So the years it's taken me to prepare the FDA application, if you just came out with an exosome 6 months ago, you really haven't had time to do that. So the regulation is actually going to be very good for the company. And I think it should be done because this idea of using tissue for therapeutic uses was never the idea. There was never the thought process. The thought process was using things like bone or collagen to replace bone or collagen. The wild west of therapeutics where anybody can say anything is not good for anyone. So, I mean, while the exosome, the contamination outbreak was, I say, good for me, I mean, it was bad for the industry as a whole. I mean, I would much rather that would never have happened. But it did happen. And so without regulation, we're always going to have those problems.
Great. Now, one other question regarding the benefits of exosomes. We know that they lower inflammation, they help with growth factors, and we also know the mitochondria in our cells are the key mechanisms by which we make energy, and energy is everything. Do exosomes help the mitochondria or our bodies make more energy?
Well, that's the great thing about messenger RNA sequencing. The difficulty with, say, protein assays, the way we've generally done it, growth factor assays, is that assay can't get inside the exosome to tell you what's really there. But if you break the exosome open and you either mass spec sequence the proteins or messenger RNA sequence, you know everything. So we've little by little going through all this data, and we think of proteins, we look to see if they're there or not, what their expression level is. But there are mitochondrial proteins in exosomes. So if you look, there's also the type of protein called a histone acetyltransferase. So I know that the expression levels of DNA are changing with these young exosomes. So in those two methods, you know that you're affecting mitochondrial function.
Okay. What different concentrations of exosomes do you sell?
I have, fortunately, because of the way I make the exosome that it's cultured, it turns out when we got the new hardware, the nanosite data did exactly correlate with the new microscope data. But that's because I'm doing it in a very purified method. If I took a placenta and squeezed the exosomes out of it, there's going to be all kinds of things in there. In fact, if you put amniotic fluid, which we do produce on the nanosite, it'll say that there's 300 billion exosomes, but I know that that's not true. There's 100 billion particles of fetal meconium. There's vernix. There's all kinds of stuff. So that's the issue with what's called a primary cell exosome. What we do is, and remember, if I started seeing therapeutic benefits from a protein concentration, I don't really care what the number of exosomes is. It's a side note. But it turns out that at a concentration of 0.5 milligrams per mil, there's about 1 billion exosomes per ml. So I have one version, which is the standard, which is 1 billion per ml. And then I have a pro one, which is 3 billion per ml. So it's 3 times the concentration. I would never give somebody of your size more than the pro, because now you're starting to immunomodulate in ways that may be too powerful. Like, you don't want a Viagra that's 10 times more effective.
Sure.
Right? And so if you say that all exosomes are alike, an exosome from 21-year-old bone marrow is not the same as an exosome from placenta. So you may need 10 times more exosomes from a 20-year-old. So the numbers are very misleading.
Okay. So if I got on would I be on a yearly exosome protocol, as you mentioned?
Yeah.
Okay. So I'm in my late 30s. If I got on an exosome protocol for it's part of my anti-aging protocol, I would put exosomes on my face or body once a year, correct?
That's the way I would look at it. And you should also, and I'm sure you do, think about all the other methods we have, say rapamycin, small amounts of rapamycin once a week. All of this to me is really fascinating with what we're finding. Right.
Yeah, I've got an anti-aging protocol, as I assume you do as well.
Well, I'm building mine out for myself.
Great.
So whatever you suggest.
Awesome. I'm happy to help you. What is, if I may ask, what is your exosome protocol? What do you do for yourself?
I treat myself every once in a while. I try to not to treat myself too much, because some of the effects I don't enjoy, such as without fail, even before when I was doing stromal vascular fraction or expanding people's cells, the patients, the men, always started to report that they wake up erect. Okay. So if I treat myself too often, it starts to become annoying.
That's a good problem to have.
So, use it in moderation. That's why I'm saying it might only be once a year. You really don't have to go too far. But when I started this, before I knew what the dosages were going to be, I gave myself 50 times the dose at the beginning. Mm-hmm. And I saw my wrinkles go away 8 months later. They came back 12 months after that. But it gives you an idea of the timing and the wave that you can use in treatment.
Gotcha. And, going back to my example, what concentration would I use once a year?
The pro, which is 15 billion placental mesenchymal exosomes.
Okay. And for people that are interested in this, how do they get these exosomes applied to them? Where do they go?
They go to their provider, or they go to exosomes.com. And that's where we do our training sessions, and that's where we link to a lot of information.
I see. So you've got to find a provider that's working with you, your exosomes, and then get those applied to them once in a while.
We have some topical cream things that we're working on that will come out.
Okay. Great. Tell us about your facility. I understand you've got a big one out in Florida.
I'm very excited about my facility. This week has been sort of a high for me, because I knew 2020 was going to be busy. That was a really long vacation we just had. Nobody was working, okay? So when it came back, it just took off to the point that I was working all day long. I didn't have time to read my emails, just running back and forth, because we expanded from a 6,000 square foot facility to another 21,000 square foot facility right next door. And the facility is really beautiful. So it's done something, not just in the terms of our effectiveness of everyone being together under one roof, but it's everybody's morale. Everybody's really excited that we can work together. In fact, one of my PhDs gave the techs a homework assignment, and they were excited about that. He told them each to write a paper about women's health issues. And the kids are in their conference room, going through papers, reading, getting prepared to write. It would never have occurred to me that they want more work, but they want to research,
Great. So aside from getting a hard-on in the middle of the night, what might there be, if any, risks of using exosomes?
I haven't seen any risks yet. I haven't seen any adverse events. I do know that I get worried if I travel without them. One time when I was in Barcelona, I fell and I scraped my arm. And it just wasn't healing, and I was there for 2 weeks. It was getting worse and worse and worse. And as soon as I got back, I just applied them topically, and it went away in 2 days. So you almost have to have this with you all the time. I did some stupid things over the last couple of weeks, and I fell. And I thought I broke my rib, and I hurt myself. And I had Dr. Park here inject me, and you could feel how inflamed I was. You could hear it in my respiration. It was like I had pneumonia. Yeah. But being able to stop that inflammation systemically is super valuable. In fact, I went to, because remember, I'm not a physician, I'm a scientist. So when I am sick, I look to physicians to take care of me. So I went to an urgent care, and they said, okay, well, I'm going to give you an anti-inflammatory. It's an injectable into my glutes. And I thought, well, should I take this? I mean, I have my own, but you know, the PA was cute, so I said, okay, I'm going to do it. So my ribs didn't hurt for the next 8 hours, but I spent the next 8 hours in the lavatory for whatever it did to me, and I felt terrible, worse than the bruise. So this ability to have an organic anti-inflammatory, I think, is the most valuable part of it.
Okay. I've heard some people say that exosomes contain foreign genetic material. Is that true? And if so, how harmful could that be?
Well, they don't contain, there's a couple things going on, and part of it is IP as to how we make it. There are companies that at the real major exosome conference I went to that were reporting that one problem is that some chromatin DNA was sticking to the outside of the exosome. It wasn't on the inside. So you can deal with that. You can deal with that by the way you grow the cells, the way you manufacture them, post. But generally, there should not be DNA in the exosomes.
So where can people find you online and learn more about you?
Well, the website is kimeralabs.com. Again, exosomes.com is where we do our trainings, and we're really trying to get people into the laboratory. We're doing it again this weekend. We even have cadavers. So we do one day of didactic, and then we do hands-on training. We let you see the microscope, see the cells. It's a lot more valuable than my just providing lip service.
Yeah, that's great. Well, Dr. Ross, I really appreciate your time. Thank you for coming on the Anti-Aging Hacks show.
Thank you.